Outstanding. So it is my sincere pleasure to introduce my friend and colleague, Amy Hotro, who is a professor and the endowed chair for pediatric rehabilitation medicine in the Department of Physical Medicine and Rehabilitation at the University of Pittsburgh School of Medicine. She's also the chief of the Pediatric Rehabilitation Medicine Services at the University of Pittsburgh Medical Center, Children's Hospital of Pittsburgh, and she's also the director of the LEND PIT program. Her research is focused on healthcare access and outcomes for children and youth with disabilities, with a special emphasis on health equity and the impact of childhood disability on families. Her work has repeatedly garnered national media attention and informed her public health policy work. In 2018, she was inducted into the National Academy of Medicine, one of the highest honors in medicine. Please join me in welcoming Amy Hotro.
Well, thank you, everyone. It's quite a pleasure to be with you. And what we're going to do today is talk about getting our own houses in order. If you've seen me present on health equity before, you have seen this slide. And I'm going to start here because I think it really speaks to me as a clinician, as a person with disabilities, as a person who's trying to make healthcare better for children, youth, and adults with disabilities, and therefore everyone. I have a few disclosures. I have a lot of grant funding. It's either related to access to care, care coordination, health equity, or it's related to the care of people with spina bifida. And I took consultant fees related to outcome measures in 2020 for people with spina bifida. Just to give you our objectives for today, we're going to start to make sure we're all on the same page with health equity definitions. And then we are going to do some self-work, and we're going to do that together as we review biases. And then collectively, we are going to share our wisdom as we engage with the health equity lens through some case-based discussions. So this is going to require your active engagement. And I'm very excited because yesterday there was so much happening in the chat, which makes me think that we're going to have a rich discussion as this kind of goes through the presentation, but even more importantly, while we're coming together to solve problems and look at problems with a health equity lens. So if you've seen me present before, you have also seen this exact slide, and it tends to be at the end of the presentation. And a wise man once said, that was Ed Shore, that we should really be thinking about not just showing what the issues are, but then talking through how we want to try to solve them. And so I put this slide up in front because I want us to be thinking about how, and we will do this together, assessing some of our biases, and then what strategies we have to reach populations in need that are underserved, who are experiencing the inequities of how the system is designed. And then thinking about when we have programs, services, interventions, what can we do to set those up and then evaluate them using a health equity lens? And then, of course, what should we be doing about advocacy for policy change? So just so it's a level playing field, this is the definition that I use for health equity. And I like it because it is both a outcomes-based definition. So the outcome is that everyone has this fair and just opportunity to be as healthy as possible. And then it has a process portion, which is removing all of those obstacles, such as poverty that relate to poverty and discrimination and their subsequent downstream consequences. And we will spend some time talking about specifically how those things interrelate. So when we talk about health disparities, what we're talking about, though, is those differences in health or its key components that adversely impact those who are marginalized. And you're going to hear me say the word marginalized or oppressed or discriminated against. And you'll also hear me use the term minoritized. So instead of using race as a proxy for the impact of racism, I'm going to use the word minoritization or minoritized during this presentation. And then, of course, the progress that we make towards equity is our reduction in disparities. And I like to give a pictorial representation of what's happening. We have things that are big issues like poverty and discrimination and oppression. And we're going to talk a lot about isms. We're going to talk about racism, classism, and ableism. And I have yet to define for you social determinants of health, the conditions that people are born into, live, learn, grow up, work in. And I no longer just use the term social determinants of health. I use the term political and social. And the reason I do that is because there are plenty of things that are maintained by reinforcing systems that are based in policy that contribute to our social views and beliefs and acculturation. And these are mutually reinforcing, whether it is about racist policies, reinforcing discriminatory beliefs, whether it's ableist policies, whether it's classist policies, but all of these are amenable to a policy intervention. So what I want us to be thinking about is what are the levers that can be pulled to make change happen. And as a young investigator, I just thought these things like minoritized race or poverty status were things I just had to hold constant and control for because they're not mutable. But many of these things are in fact quite mutable if we are willing to do the work as a society to get there. And when we have poverty and all these forms of oppression, we end up with problems with housing instability, food insecurity, lack of stable employment, poor quality education, and then where we sit, the lack of access to the supports and services that really promote health. And so what we end up is this, poor little one deep in the water without a flotation device. And we're just trying to drag them back from this place where they have been kept down, pushed down this river from these upstream forces. And then the downstream forces are not helping. And where we can make change happen, whether it be at this level or at the policy level, are things we're going to talk about today. If you've seen my presentation, you have also seen this slide, and I really like it because we're talking very basically about fundamentals. That's what we're often referring to when we talk about those social determinants, political determinants of health. But I also want to spend some time on this pillar right here. So I think that discrimination has a big influence. When we are repeatedly told that we're not good enough, we don't belong, we don't look right, we don't think right, we don't act right, really minimizes our opportunities to develop esteem and self-actualization, the goals that we have for all children, including children with medical complexity and disability. And no presentation of mine would be complete without a quote from Mr. Rogers. And for me, this speaks to something that really is a very clear indication of what we need for population health, knowing that we can be loved exactly as we are, gives us the opportunity for growing into the healthiest of people. And although these are not the words that he spoke, I think this is a push towards eliminating oppression, discrimination, and marginalization. So I'm going to give you some examples of the conditions in which children with disabilities, children with medical complexity live in. The first one I'm going to give you really relates to feeling secure and safe in your own environment, and that's related to adverse childhood experiences. Let me orient you to this slide briefly. So this column is children with disabilities, and I have used a definition from the screener about functional limitations. So it's a relatively strict definition of disability, and mostly kids in medical complexity will fit under that definition. And then no disability. Green is good, means go, no adverse childhood experiences. We want this to be as tall as possible. And you can see that there's clearly a disparity or a difference in the experience of any, so yellow or red, adverse childhood experiences for kids with disabilities compared with those without. And oh man, you guys, stop the presses. Nearly 40% of children with disabilities are experiencing more than 2 ACEs. So think about thriving and think about how the circumstances that have been socially and politically created for this child with disabilities are really going to limit. And then let's talk a little bit more specifically about ableism. So I'm going to use bullying as an example of how ableism plays out for children on the playground at school. So again, green means no bullying. So bullying less than once a year. So that's good. Yeah. This is at least yearly. And these groups are pretty similar. I've got kids who are more complex here, less complex here, and without special healthcare needs over here. But stop the presses. We've got 15% of kids who have more complex healthcare needs who are being bullied more than weekly. how do you think that impacts their sense of belonging, their sense of opportunity, their sense of self? What does that set them up for achieving the pinnacle of the where we want things on Maslow's hierarchy of need, self-actualization, self-determination, autonomy, independence, if that's desired in life. So we know that children who are from minoritized backgrounds, children who are poor, are more likely to have special healthcare needs, especially those special healthcare needs that are not related to only prescription medication. But within the population of children with special healthcare needs, I took this graphic from Jeff Schiff's paper from Blueprints from Change. There's a lot of difference in the experience of poverty by different minoritized group. So this right here are white children. And as you can see, a very small proportion of them are living below the federal poverty level, so in poverty, compared to Blacks, Hispanic children, Native children, and Pacific Islander, Native Hawaiian kids. And they have a much larger proportion of white children living far above the federal poverty level. If I break this down for you and we look at disability specifically, I told you I used that metric from the screener, which is a pretty restrictive measure, gives us less than just about 5% of children overall have disabilities. And I am using this schema, and I'm going to use this color schema kind of throughout, that we see that we have kids who are living under the federal poverty level, having much higher rates of disability. And there's actually a stepwise relationship here. And so some of you may be familiar that both poverty is a cause and consequence of disability. And so we can say that in the reverse way as well. Disability is both a cause and a consequence of poverty. And I'm going to share data with you that's really going to bring that home, I think. But I want us to make sure that we're staying in this really intersectional space. Many children with disabilities are multiply marginalized, meaning they're here more likely to be poor, and also they're more likely to be from a minoritized background. So disproportionately Black minoritized background. And you might say, oh, there's something about their genetics or the condition that must explain this. And there are very few conditions. Let's take sickle cell, for example, that may be disabling, that are really so tightly linked to someone's race, which, by the way, is a social construction. And it is the social and political construction of minoritization and oppression that we're really talking about here. So I want to spend some time kind of integrating the ideas of how this impacts children and families when we're thinking about the issues around poverty and how people with disabilities are kept poor and how there are limited opportunities for those families. So I'm just going to show you some data. So this is for time spent providing care in a week and arranging care in a week. And I'm only showing you the data for simplicity's sake for those kids who have more complex special healthcare needs. So as you can see, there is a variety of hours spent, right? But 22.4% of families are spending at least 11 hours providing direct medical care, and 6% of them are spending at least 11 hours arranging that care. So right off the bat, you can see how it might be very challenging kind of structurally to provide all this care and also have a job that gives you income, right? And we talk a lot about the workforce for in-home care and supports the unpaid labor that families do. And even when they are paid, it's not paid at a rate that is appropriate for the work that goes into it. So I'm all about this intersection. So what I'm going to show you is it by income. And again, the income gradations are such that the lightest color are children living in poverty. The darkest color are children who are far above the federal poverty level. And both for providing and arranging care, you can see that it's disproportionately experienced by the families who are living in or near poverty, which means they are experiencing this disparity or inequity for opportunity for employment that might give them the income to get out of poverty. There may be policy solutions to this, and maybe we should talk about them. So who has to stop or cut back work? So when we look at it by complexity, so it's definitely experienced much more So by those families who have more children with more complex medical needs. And I think obviously that makes sense to us from a perspective of like more care needs, more likely to need to cut back on work. But who does that impact? Oh, right. It is the families who live in or near poverty. It is the families who are from minoritized backgrounds. So this is where those intersections really matter. So when you're multiply marginalized and your families are experience the impacts of policies that don't promote your opportunities to get out of poverty, then it becomes entrenched. And it seems pretty obvious to us then how poverty is a consequence of disability, and that the social structure and the political structure that we set up perpetuate that. And we could have an hour-long conversation about that alone. But I think it's really important for us to now locate ourselves right in kind of the health service space. So we know you have to be able to access it. Access was another key pillar from the Blueprints of Change, which hopefully you guys have read, that was led by Dennis Quo. And I'm going to share with you, and I'll share a series of these slides. So these are kids without disabilities, and these are kids with disabilities. And we're talking about access to the medical home in this one. So here is the percentage of kids with no disability. So about 50% who are getting care within a medical home. That doesn't seem so great because this is the standard of care in pediatrics. So what that means is we have this massive opportunity. But it's even worse. There's a disparity or inequity here for children with disabilities. So not only do we have the opportunity to get more kids with disabilities medical homes, we have an opportunity to reduce the disparity, to work towards equity. And so when you're thinking about programs and services, we want to be thinking about, well, what are the levers that we can pull that are not only going to raise all these votes, but specifically make sure that we raise this vote, and that we then eliminate the inequity. One of the other pillars in the Blueprint for Change was financing. And this is a metric of having both adequate and continuous insurance. Again, it's the no disability and disability groups. And as you can see, there's a disparity here, so that people without disabilities, their families are more likely to report that they have adequate and continuous insurance compared to those with people with disabilities. This clearly remains an opportunity, and it is also an opportunity for us to reduce the disparity. So I think when we think about the systems of care for children with special healthcare needs, and then think a more smaller group, kids with disabilities within that group, kids who have medical complexity, we know that it's been really hard to make sure that they have care within a well-functioning system. And in fact, we're just not doing great overall for all kids without disabilities. So there's a gigantic opportunity here, right? But whoa, you guys, this is craptastic. I mean, this opportunity gap is just huge. Holy moly. I mean, we're talking about 10% of kids with disabilities. And so there's a big gap, that's the equity gap, and then there's also gigantic gap overall. So when you don't have care within a well-functioning system, how does that impact families? So families often report frustration. So this is a graphic where I have combined the three categories we've been looking at: complexity or disability status, income, and then minoritized race. And overall, about 17% of families report they're frustrated with getting care. And that is disproportionately felt by families who are more medically complex, families living in poverty, and Hispanic families. So this disproportion, these uneven bars, clearly tell us there's opportunities for equity. And we know there's multiple reasons people might be frustrated, but what I want to do is do some self-work, us together doing self-work. So let's talk about bias, okay? What we are not going to do today is spend time doing anti-racist education. I think lots of us have probably already started that work, and it's exceptionally important. But I want to do some things where we see kind of some other forms of biases at play. So not just our implicit biases about race or gender or disability status. And you guys, many of you know that I'm like so wanting to be a guest on Sesame Street as a doctor with disabilities who takes care of kids or Muppets with disabilities. But this quote is from Avenue Q, which is not appropriate for children, so grown-up Muppets. So let's get into it. Which line is longer? You can, put it in the chat if you want. You can just look at it and say in your head what you think this is. But, A to me looks like it's longer, right? And you may have seen this one before, and you know that in fact, these segments are equal. And you're like, oh, damn, they still don't look equal, even though I know they are. Let's prove it. They are in fact equal. So that's just an example of a visual illusion. And it taps into how our brains reflexively process information, just like all these unconscious biases we might have about race or gender or immigrants or people with disabilities. And this played out a few years ago with this internet sensation, right? So what color is this dress? In all seriousness, is this dress gold and white or is it black and blue? I would love to see some hands who thinks that this is a gold and white dress. Raise your hands in the room or in, all right, yes, we've got some people right here in the Zoom room saying that they think it's gold and white. Put down your hands. Who thinks this is black and blue? Raise your hands, black and blue people. Who's got some black and blue? So it's totally nuts to me that we are looking at something and the exact same picture on the exact same screen, and we're like, no, they are different color schemes, right? We are convinced that at least that I'm seeing a dress that's gold and white. It's how my rods and cones are taking in information. It is likely that the people who saw this as black and blue might be a little bit younger than those of us who saw it as white and gold. And I want us just to hold that there's nothing that says, oh my gosh, you're a horrible person because your rods and cones work differently. And I want us to start to feel comfortable in the uncomfortable space that our perceptions shape our understanding of reality. And so this I just use for that purpose. So let's go to something, that happens like for some of us every day. So don't worry, I'm not getting paid by Starbucks. It's not a disclosure that I needed to make. But like you're at Starbucks waiting for your drink and the barista calls out pumpkin spice latte for Aaron, pumpkin spice latte for Aaron. And you're surprised when this dude goes to pick up that drink because you were pretty sure this person was going to go pick up that drink, right? You're like, who drinks pumpkin spice lattes? White girls. And you kind of reflexively were like, oh yeah, well, of course, this biker guy could like pumpkin spice lattes. There's no reason. But you just took in, over years of getting lattes at Starbucks, you have formed kind of a sense of the way things are. And so you seem surprised when the biker guy goes to get his latte. This is a good time for us to take just a moment between something that's explicit versus implicit. So explicit, like we know what our interests and choices are, right? So let's take me for an example, right? You guys know I love glasses. So, right, it's pretty obvious that I'm not going to pick these glasses over here. I'm going to pick these glasses. And I mean, come on, right? I should buy these glasses. I should definitely buy these glasses, right? But I have an explicit preference, right? And it is within my cognitive awareness of my preferences. You know my preferences so well that you could have judged for me. So the problem here is that for implicit things, it's not usually accessible to our conscious awareness, but it does shape our understanding of the world. So let's take it from the mouths of babes. So one year, I was handing out candy on Halloween for trick-or-treaters, and I was dressed in a costume. And these two cutie patooties show up at my door, and I put a piece of candy in each of their little baskets, and the little boy starts to cry. And I say, oh, you don't want that piece of candy? You want a different one? I can give you a different one. And he's sobbing, and he, with his lip quivering, as empathetic as a kid as he could possibly be, says, why don't you get to go trick-or-treating? He is so upset on my behalf, right? This little girl, she has her hands on her hips and she turns to him, because she's a mommy. And what happened there was he was taking in information that he saw about me, that I am little and that I am wearing a costume. And he really loves trick or treating and knows how great it is, and thought, here's a kid who is not getting to do the thing that I love to do. So what a sweet, empathetic kid. And here's another kid who said, well, this person is a woman and she kind of looks like a woman and she's at the door of the house and she's handling things. That must be a mommy, right? Oh, a non-benign example, you guys probably know about this, like children as young as 3 years old, minoritized Black children, will pick the white doll as the pretty one. So they're internalizing already the kind of societal level racism that exists. Or how about from the perspective of ableism? I have a bunch of kiddos in my clinic that use wheelchairs for mobility. And when they're 4 and 5 years old, man, people love it, right? Little kids love wheelchairs. Wheelchairs are so cool. They're the coolest kid in the playground. But by the time they hit first or second grade, those other children have been acculturated with an ableist mindset. So then these kids with disabilities are often left behind by their peers. And guess what? 15% of them are getting bullied at least weekly. So let's rein this in though. So now we're talking about kind of big picture biases in all the different places. Let's talk about it from a healthcare professional perspective. So unfortunately, when implicit bias infects us in healthcare, there's a negative relationship between bias and quality healthcare. And specifically, when we look at racial and ethnic bias, stronger biases were associated with poorer communication. So what do you think on that? Let's take some other biases. Actor-observer bias. So this is also called a fundamental attribution error effect, but it's our tendency, all of us, but including those who are involved in health services, to explain other people's behaviors more based on the influence of their personality versus the influence of the situation, the kind of social, political determinants of health, and then the on-the-ground situation that they have. So what about this? Gah, I wish that mom would take her child's health seriously and come to clinic on time. Well, if this is how we feel because we have an actor-observer bias, that we're blaming the mom for not coming on time, saying that's because she doesn't take things seriously, well, how is it that we are putting those feelings aside to provide the best care? Frankly, I think it means that we're not. And who is it that we might say that's about, right? So families with more limited resources, right? The influence of their situation. Well, guess what? We're not doing so great with families who have limited resources in providing family-centered care. The crux of family-centered care is about communication, right? This may be part of the reason why we don't do so well on medical home. And this stepwise relationship, I show it to you over and over again. We have so much opportunity to reduce the inequity. And I believe that our biases take a heavy toll on our ability to reduce that inequity because we don't really understand our biases, which is why we're doing this work together right now. I could show you the same graph, right, by minoritized race. So these families are much less likely to report that they're getting family-centered care. So we are going to take a journey on reasoning. So just to remind you, deductive reasoning is an inference, and it is valid if the conclusion logically follows the premise. So an inference is just that set. It's the premises coupled with the conclusion. Let's talk about frogs. All frogs are reptiles. And let's talk about cats. No cats are reptiles. So let's make a conclusion. Therefore, no cats are frogs. Ta-da! Right. All right, let's do it again. We're talking about frogs and cats again. This time, no frogs are reptiles. I know that's wrong. That's a premise, right? Another premise, all cats are reptiles. Let's make a conclusion. Therefore, no cats are frogs. Well, it turns out that the conclusion is valid, but the argument is not sound, right? These premises are not true. And unfortunately, this happens a lot in how we judge people. So how about this? I'm going to say something that is a very commonly held classist belief. In America, anyone can make it if they work hard. People who are rich are being rewarded for working hard. Those are my premises. And my conclusion is, therefore, poor people must not work hard, right? So oftentimes we do not question what the premise is, right? The idea that people who work hard are rewarded by riches, and therefore people who are poor must not work hard. That is not a sound argument, but it is one that gets made over and over again. And our implicit biases just get reinforced. I'm going to ask you to play a little game with me. This is the Watson selection task, also known as the 4-card problem. We've got 4 cards, and each of these cards will have a number on one side and a letter on the other. Here's a rule. If a card has a vowel, like this one that's an A, E, I, O, or U, then it has an even number on the other side. So 2, 4, 6, 8. How will we prove that this rule is false? Remember the rule, a vowel on one side, then an even number on the other. So you're going to put in the chat, or you're going to think it to yourself, or whatever. Which cards do you want to turn over? Most people say A, because they're like, yeah, I got to check to see if there's an even number on the other side. And then most people say 4. I got to see if there's a vowel on the other side. But you really need to turn over that 4, right? Is there not anything in the rule that says if it's an even number on one side, it must be a vowel on the other, right? The rule is the reverse of that. So maybe we don't need to do 4. How about just A? That's what people will end up with. So now I'm going to ask you, is that enough? Have we really done everything we need to do to prove that this rule is false? Right? When it's a true false dichotomy, we can say, how do we prove it true, or how do we prove it false? I'm using the word false for a purpose. So what about card number 7? What happens if we turn over the 7? And what happens if it's an A, E, I, or U? So if it's an A, E, I, or U on the other side, it will disprove this rule because this is an odd number. What happens in the Watson selection test is something called confirmation bias. And now let's like rope this into healthcare, right? Confirmation bias happens all the time in healthcare. We give greater weight to things that support our preliminary diagnosis or original thinking, and then we overlook or dismiss data that doesn't support that. So we use things to confirm, but not disprove, which is what the Watson card problem is all about. We often have anchoring bias, and we might be overconfident. How does this happen for kids with medical complexity? Let's say that kiddo has their hips out of socket, spasticity, they have some pain there, and they come in with some vague complaint of pain. And because they have these hip problems, the provider is like, well, I've done an exam, I can't quite find it. Yep, it pretty much seems like must be the hips, right? I'm going to anchor and confirm based on this preliminary diagnosis, and I'm not looking for other things. Well, that makes you miss an opportunity for something happening in the GI tract, something that might be amenable to treatment. So when we have confirmation bias in healthcare, we're delaying adequate treatment. And we also, because we have all of these biases that we don't have at the front of our brain, maybe doing that differentially for different people, meaning that people who are from minoritized race aren't listened to in the same way, which we know to be true. It may be that is true of families who are in poverty, families who have a child who's very complex, right? So all of this matters, obviously, because we want people to be as healthy as possible, and we want the experience of care for people to be better. And we need that to be better equitably so, right? Because that's how we will optimize health across the board. It also helps us when we address our biases to be optimizing ourselves as a workforce. And hopefully all of this leads to reduction in cost. So I'm going to flip us now in these last 19 minutes to do some work together, right? I am excited to share with you some problems, and we're going to take an equity lens. Attendance policies, that's our first case. So you can imagine that you are a parent of a child with medical complexity and you're reliant on non-emergency medical transportation services for your child to attend their therapy appointments. For those of you who are not familiar with that, so often what happens is you get a time window. I think some people would see it as lucky if it was just a 2-hour time window, and the non-emergency transport is often late, and occasionally they don't arrive on time or don't arrive at all. So that makes you late for your appointments. And the way the attendance policy at the clinic is written is you get 3 strikes. You're late, you didn't show, you're late, you didn't show. Guess what? You can no longer get services there. You've been kicked out. So who does this really impact? When care is foregone and transportation is an identified problem, who does that impact? Of course, it impacts those families of kids with medical complexity, right? Because those children are just not getting in necessarily into a car and sitting in the back seat with a booster seat, like kids without disabilities, kids from minoritized backgrounds, kids who live in households with fewer financial resources. It is really hard to pay for a wheelchair accessible van if you do not have a lot of money. And so let's just briefly look at the actual data. So this is by poverty again. So when transportation is identified a problem, it's much more frequently a problem for people living in poverty or near poverty. So here we've set up this inequity, right, with the policy of the attendance. So what things can we do to make that attendance policy more equitable, right? That is the very first question that I thought of when I was working through to make these cases. But is that really the right question? Right? Maybe I'm thinking about it from my perspective as someone who works in a clinic and may be able to control the clinic, but maybe there are other questions that we should be asking. Maybe we should be making sure that we are thinking about the upstream and downstream factors. Maybe the locus of where we need to make an intervention is with the non-emergency transport, or maybe with where clinics are located. So maybe if you want to tackle one of these, how could non-emergency transport be improved? How could clinics ensure appropriate public transportation, so like paratransit, accessibility of their spaces? And briefly, for you guys who are not familiar with non-emergency medical transport, it is a federal Medicaid requirement. And the states have various ways that they can do this, and they're reimbursed. So they can either do it as a medical service and get reimbursed that way, or they can get it as administrative expense, and that has a lower reimbursement, but then that eliminates some choice and makes it maybe easier for states to contract with a single provider, which then of course makes it more likely that the service isn't that great. So here are our tasks. What are some operational changes we can make? What are some QI project ideas we might have? What are some policy advocacy solutions? So I'm going to finally stop talking and bring it to the room so you guys can share your wisdom. We're thinking on equity here. How can we make this more equitable? I've got people putting things in the chat. Yes, please use the reaction button of raising your hand if you're here in Zoom. And if you're in the room, you raise your hand and Libby will call on you.
I see Chris still has something to say in the room.
Okay.
Great.
Frantically waving. Thank you, Amy. This is a great thing. I wish we had more time. A couple of things is basically to take the burden off families. Focus more on the NEMT providers, modify or get rid of the 3 strikes and you're out policy. While at the same time, I mean, you need to sort of balance that 4th part of the quadruple aim, to keep things feasible for clinics, but really try and get rid of it as much as you can. Those are things that we've actually done in our complex care clinic. And then the third thing is just encourage families to call if they think they're going to be late, because that really, really, really helps. So everybody can help.
Great, thank you. We have some great recommendations in here, right? So what about a Lyft membership so they can arrange their own transportation? Some states use Kiwanis Club for transportation or have some sort of partnering with the Children's Hospital. Share your experiences with your state representative as an example. Do we have anyone else? We have Kathy in the Zoom room who has a comment.
And this may be happening already, but care coordination, case manager involvement so that there's full awareness on both sides as to what's going on that might help with crafting a solution with transportation.
Awesome. Here's something, change how clinics run so that you can have drop-ins or walk-ins same day. That's great. I love all the creative thinking here. I've got Peggy in the Zoom room. Is there somebody in the physical room that we need to put
Yeah,
in?
we're alternating, Amy, just so you know. So we have Steve in the main room.
Great.
Depending on the size of the clinic, but the clinic could buy a van and provide the service themselves.
Right. You know,
These
lots
are
of
all cool.
hospitals have their own emergency vehicles, right? Why not their own non-emergency vehicles? Great.
I would wonder about meeting with the transportation office and seeing what their what policies could be changed in terms of the delays and the pay that is given to these drivers.
Right, because they're not incentivized necessarily in the ways they need to be incentivized. I'm sure there's like 1,000 examples that people could come up with of how poorly non-emergency medical transport has worked for them. Great. I love this, moving upstream or allowing practices a longer window for appointments if someone isn't on time. Mobile clinics. You guys, this is so great. Because you know, what happened in one of those early slides is that that came from the presentation I give about health equity is like meet people where they need to be met, right? And so maybe mobile services are a way to do that. And then, you know, addressing this fundamental, the upstream factors, the original source, right? Gosh, you guys are wonderful. Do we have anyone else in the main room?
We have two more in the main room. We have Jill and then Mallory.
Great, let's take them.
I was thinking for rural communities, low access communities, that the state themselves make sure that clinics are aware of that policies, are aware of access so that they can do their own van, they can create mobile, so that there is this communication within areas that have little to no transport anyway, so that there's good communication and across reservation lines, make sure that there is communication for those families who need specialty care outside of Indian health and outside of Indian country, so that there is access to transportation.
Great. Thank you for that. And my goodness, you know, if it isn't another multiple marginalization that happens for our rural families. Thank you for bringing that up. And we have one more person in the room.
Yeah. Hi, this is Mallory. So I actually used to manage the NEMT benefit in Colorado, so it's really hard for me not to like contribute. Obviously, it's a very, very complicated benefit. And Colorado is a huge state, so there are a lot of inequities. We tried a statewide model, and it really, you can't. It's not a one size fits all, especially in rural areas. But all that being said, a couple of things that are a possibility. Sometimes families can just get reimbursed for mileage using their own transport, depending on all the nuances and policies. Another thing that we really tried to do was support like local community, churches or trusted people that were already bringing people to appointments and helping them to become providers, or be able to get paid for, the work that they were already doing because they were a trusted leader in the community. So looking for those options as well.
Wonderful. Oh my gosh. And someone who's got all this expertise. So, what's really beautiful in the chat is talking about like maybe there's performance measures, right? And maybe there is things that we do that are beneficial. The curb cut effect, sidewalks and public infrastructure are good for everyone. These are wonderful. And, if this is a problem in your state, I wonder that if you take this kind of problem back and think about where do we make changes? What levers do we pull? Is there something that we could be doing where we're doing measurement and quality improvement? And then, of course, how to be advocating. And a lot of people put into the chat examples of how that might happen. I'd like to move us on to the next case, if I might. So I'm calling case number 2, keeping the lights on. In this situation, you are a manager of a primary care clinic. And reimbursements are going down, costs are going up. There's so much paperwork to do. You've got providers threatening to quit. You have already shortened their appointment times to 15 minutes. Man, they cannot keep on time. Whenever there's a kid with medical complexity in clinic, they make them late for every other patient in the queue. And these families are complaining because the provider is always late. They're grateful that they, get the time that they get with the provider, but don't want to spend so much time waiting for them. And you're like, how am I going to keep the lights on here? I can't increase volume. And you think to yourself, Eureka, I have an idea. We need more privately insured patients to offset our lower reimbursed Medicaid patients. So what do? You talk to your legal team. Can I limit access for my Medicaid patients? Turns out you can't eliminate it, but you're probably going to be okay if you limit it. You still have to have appointments available. So what do? You change your scheduling pathway to make it so that out of the 100 slots that are available for patients, only 5 of them are available for people who have Medicaid. And that is really going to shift this, right? So this is the distribution of how kids are insured nationally currently. And you're saying, I'm going to make this black part of the pie nearly the entire pie because that way I'll get more reimbursement. And you think to yourself, cha-ching, 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 you have solved the problem. But by doing this, you have made a major inequity, right? So this is the percentage of children who are covered by private insurance alone. So not both public and private. So guess who is covered by private insurance alone? The more well-off families, the white families, the kids who either don't have complex healthcare needs or don't have healthcare needs, okay? Well, great. Look at what we have done. We have made it harder for the already marginalized folks to get the care and services they need by limiting their access based on their Medicaid status. And this has profound implications. So I'm just going to show you. We're going to talk about what we will do to address this inequity, but just to prove a point. The studies show that for every $10 increase in a Medicaid reimbursement per visit, parents were 0.5 percentage points more likely to report that they had no difficulty finding a provider for their child. So this is like directly impacting in the real world right now, access to care for kids who are on Medicaid. So our group tasks are to be thinking, well, what operational changes should we make? Do we have a quality improvement project that might work here? What are some advocacy or policy solutions? And there's no perfect solution here. We know that our choices have consequences, but I want us to talk and dialogue again. So, raise your hand if you're in Zoom, in the raise hand function or in the room. But I want to talk about like when we do something to keep the lights on, how we might be perpetuating inequity, and then how we're going to address that.
We have Rhonda at the front of the room.
I think first understanding who your Medicaid population is. Is it children with medical complexity? And if that's the case, can you increase the reimbursement and the office visit time? And work with your
Right.
Medicaid group to do that.
There seems like a quality improvement project right there, how to optimize your reimbursement for the subset of patients that might be vulnerable or oppressed through this change. Great, thank you. How about Kathy?
Sorry, I have too many buttons to push. So we did some work similar to this a number of years ago when I was with the CHIP program around dental access, primarily for Medicaid enrolled kids. And, you know, we really took sort of a multi-pronged approach. We talked to the families, you know, had some focus groups. What are the barriers with the families? And it was supported by the governor at that time. We had a task force put in place for months, and we raised dental rates, Medicaid dental rates to the commercial rates, the Blue Cross of Alabama rates. But then we did an educational campaign for the families as well. You know, what are your rights, but what are the expectations? And, you know, I don't have any data to particularly show the outcome other than anecdotally, I saw an increase in dental access for Medicaid enrolled children. We did have some clinics open, which really they serve both insured or at least CHIP and Medicaid kids. But there was this niche where they saw where they could make a profit by seeing this. So, but then it was funny because the private dentist fussed about the clinics, and so more of those started taking Medicaid. So it was really this multi-pronged approach that included rate increases, but that was not the only thing.
You have just like sung the song. Like, we often need a multi-pronged approach, right? It's not just one thing. It's not just one lever that we pull. So that's why we have like, all of these possibilities. You know, what are operational changes, QI opportunities, solutions from a policy perspective. We're wrapping up. And so I'm going to give you guys some homework, right? So you are working on demonstrating how your program works. And you know from families that it's not just about physiologic outcomes or hospital days. And you meet with the health services research team from a nearby university, and they recommend, of course, quality of life. And they say to you, let's use the PEDS QL. They use it all the time. And in fact, it has been in the published literature indexed on PubMed 1,600 times in the past decade. But you realize that this is really just a measure of function. They also say, oh, you know what, how you can really prove this is good is quality adjusted life years. That's like the gold standard of valuing and evaluating the impact on health. But you recognize this is discriminatory because it sets up the allocation of resources lower for people who have disabilities. And you recognize that families will experience this as ableism when you tell them that their child doesn't have a good quality of life because they have limits in their functioning. So, you know, what do? How do you find measures that aren't ableist? How do you educate others and take an anti-ableist lens on things as part of your health equity work? So I really encourage you to kind of think about that when you're designing your evaluations. And I'm going to leave you obviously with just the cartoons that I often leave people with. So here we are, only one person can watch the game. And what we do is we give out some boxes, and that's the equality. Oftentimes, people with disabilities are just totally ignored when we think about issues around equity or equality. And that's why this little one doesn't have a ramp. So here's more what equity looks like, right? But we also have to recognize that this really isn't the circumstance. This is the political determinant of health that really entrenches inequities. And so that we have to push our policy levers. So many people call for liberation, right? Mr. Gorbachev, bring down that wall. Because then you don't need to add these boxes and ramps. Everyone can see. But I don't like that because I think the fence has meaning and purpose because it's protecting the players from the spectators, it's giving a demarcation. But this is what I think justice looks like from a health equity lens for regardless of your race, your class, your disability status, your immigration status, anything that makes you puts you in a class that has been historically and continually oppressed. So this is what I think justice looks like, and this is what our goals are long term. But as we're working towards those goals, we know those boxes and ramps are necessary in the work that we do. So as you're thinking about the work that you do, please hold in your hearts and in your minds how you take that health equity lens on every aspect, on designing programs, evaluating programs, and advocating for change. So thank you. I think we're headed towards a break.